Hello, my name is Brent Zutaut, and I am an undergraduate student researcher with the West Virginia University School of Medicine, Department of Orthopaedics. Today, I will present to you a retrospective case series on severe cervical spondylodiscitis treated with combined anterior and posterior surgical instrumentation. Cervical spondylodiscitis is an infection occurring within the vertebrae or discs of the cervical spine or neck. It is a relatively rare condition, but it is one recognized for significant morbidity and disability due to high rates of neurologic compromise and structural instability. Often, cervical spondylodiscitis is treated through medical management with IV antibiotics, but surgery may become necessary if neurologic compromise or biomechanical instability develops. Surgery can involve isolated anterior or posterior approaches with possible instrumentation, along with a combination of the two. The chosen surgical approach is dependent on the location of the infection and the degree of compromise or instability present. The rarity of the condition has led to a scarcity within the literature, and further, a lack of consensus on optimal surgical treatment. This case series presents our institutional experience in treating severe cases of cervical spondylodiscitis with combined anterior and posterior surgical instrumentation. Through the retrospective review of our institution's experiences, we aim to identify patient factors common to those with cervical spondylodiscitis and factors that place patients at risk of surgical treatment failure. We performed a retrospective chart review to identify all patients treated with combined anterior and posterior surgery performed either under the same anesthetic or in a planned staged fashion for cervical spondylodiscitis at Ruby Memorial Hospital between 2011 and 2019. Patients were excluded for non-infectious etiologies, ages under 18, and separate or unplanned anterior and posterior surgeries. For each patient that met inclusion criteria, demographics, comorbidities, lab results, surgical details, and the need for revision were collected. Following collection, descriptive statistics, logistic regression, and chi-square analysis were performed on the data. 18 patients met inclusion criteria. 11 were male and 7 were female, with the average age being approximately 50 years old. Each patient was treated at our institution with combined anterior-posterior surgery for cervical spondylodiscitis. 3 were treated in an intentionally staged manner on multiple days, while the other 15 were treated under the same anesthetic. 16 of 18 patients had multiple comorbidities, with each having at least one of the following: diabetes, hepatitis C, intravenous drug use, or end-stage renal disease. The 3 most common comorbidities were intravenous drug use reported in 8 patients, diabetes in 6, and hepatitis C in 6. 7 patients had concurrent infection sites elsewhere in the body, and 4 had secondary spine infection sites. The following lab results were found within our study population. Approximately 80% of subjects presented with biomechanical stability compromise and approximately 40% of subjects presented with neurologic compromise. 2 had complete spinal cord injuries, 4 had incomplete spinal cord injuries, and 1 had a root level deficit. In our limited study population, a higher erythrocyte sedimentation rate significantly correlated with an increased likelihood of neurologic compromise at a p-value of 0.02. Surgical indications included failure of prior medical standard of care management, which includes IV antibiotics for 2 patients, revision surgery for failed prior standalone anterior surgery that was performed for cervical spondylodiscitis, with failure defined as biomechanical instability or recurrence of infection following the index surgery for 3 patients, and the remaining 13 patients required surgery for acute biomechanical instability, neurologic compromise, or both. Following treatment at our institution with combined anterior-posterior surgery, surgical outcomes included 0 biomechanical failures or instrumentation revisions, and 1 post-surgical infection requiring washout and closure, which then resolved. Cervical spondylodiscitis is a complex problem that presents with a high rate of neurologic involvement and involves patients with multiple comorbidities. Our study population correlates with existing literature on common comorbidities and microorganisms. Within our study population, 3 patients required reconstruction with combined instrumentation for failed prior standalone anterior surgical treatment performed at outside institutions, while all combined anterior and posterior operations proved to be structurally and neurologically durable. This suggests a more biomechanically stable construct achieved through a combined approach of the index surgery may be preferable in this less intrinsically stable part of the spine to prevent failure, despite the more invasive nature of the approach. We are currently performing more work to compare risk factors for failure between standalone anterior procedures versus combined anterior and posterior procedures for the treatment of severe cervical spondylodiscitis. Thank you to everyone on my research team for giving me the opportunity to work on this project and their significant contributions to this project. Thank you for joining me today for this presentation. If you have any questions, comments, or concerns, please reach out to me via email using the address in the description of this video or comment below.